we get more than 100 participants?
Yes, it is on, ma'am. See, it is on.
Okay.
Meeting is now streaming live on the
Okay.
YouTube.
Let's start, Vishal.
Very good evening to you all. Very good evening, President Sir, and very good evening to you all. With your due permission, should we begin the webinar, President Sir?
Please start.
Over to you, Dr. Shraddha, ma'am.
So, good evening, one and all, and we welcome
You kindly
to
request you to make me the co-host, sir.
Should I start, sir?
Please, ma'am.
Yeah. So, good evening, one and all, and welcome to the Rsacp webinar hosted by the Rsacp Nagpur branch. And the theme today is intraoperative cardiac events. As anesthesiologists, we all know that we frequently encounter cardiac complications, often during our surgeries, which makes it a critical aspect of our daily practice. This webinar will delve into the strategies, expert insights, and best practices for managing such intraoperative cardiac events. And so let's explore this vital topic together and enhance our skills with our expert faculty. And we have some very eminent chairpersons to enlighten further on this session. But before we start, I request President Rsacp, Dr. Naveen Malhotra, sir, to kindly give a welcome address so that we can start on. Naveen, sir.
Thank you, Dr. Shraddha. It's really heartening that I'm present here addressing as president to the webinar which is being hosted by Research Society of Anesthesiology, Nagpur City branch. And all dear friends are here, led by past National President of Research Society of Anesthesiology, Dr. Indrani Hemant Kumar, Madam. Namaskar, Madam. Very dear Dr. Anjali Bhure, Madam, the past National Vice President of Indian Society of Anesthesiologists and a very good friend. And ably following their footsteps, Dr. Gauri Arora, a very vibrant and active National Governing Council member of Research Society of Anesthesiology. And I know Dr. Vishal Singla, the Honorary Secretary, and Dr. Gauri Arora have been working behind the scenes to make this webinar highly successful. I am also thankful to Dr. Geeta Elawat.
Thank you, sir.
Now currently my successor at Department of Cardiac Anesthesia. She is now Professor and Head of Department of Cardiac Anesthesia at PGI Rohtak. So we have got second rung of leaders who are now taking the responsibilities, and I'm very happy that Dr. Geeta Elawat is joining Dr. Indrani Hemant Kumar and along with Dr. Anjali Bhure and the three good speakers. I personally feel that any webinar or any scientific program is successful because of the faculty. Dr. Shilpa Tivaskar, very good friend and very sincere worker. She is the state representative of Research Society of Anesthesiology in the National Governing Council, and who is moderating another state representative in the National Governing Council of Research Society, another dear friend, Dr. Shraddha. And we have got the other speakers. So it's all, I am really, Dr. Asai is the odd man out along with me and Dr. Vishal. It's all a ladies den today. And it is followed by Dr. Ridhima, a very good colleague and junior, and who is now placed in AIMS Nagpur. And I'm sure that she will be bringing more laurels to herself and make us pride by winning more awards and orations. So I will not stand between you and academics. God bless you all. And I'm also eagerly waiting to listen about the hypertensive crisis, ischemic crisis, as well as arrhythmias, and how to prevent them. And if at all they occur, how to correct them immediately. Thank you very much. And soon, our young team of Youth Conclave, led by our National Youth Governing Council members, Dr. Neha Sinha, Dr. Tanveer Singh, and ably supported by Dr. Neha, another Neha from Kanpur, and Dr. Nitin. They will be starting the Youth Conclave, the virtual event, in the first week of June. And it will be followed by the launch of Research Society of Anesthesiology and Journal of Anesthesiology Clinical Pharmacology Editor Fellowship. So all-round academic activities are going on, and I thank Dr. Vishal Singla for keeping a good track of all those things. Thank you very much. God bless you all.
Thank you very much, Naveen sir, for all the motivation and encouragement. I would also now request Dr. Vishal Singla sir, Secretary RSACP, to kindly say a few words before we start off the academic program. Vishal sir, please.
Thank you very much, Dr. Shraddha. Good evening, everyone, and greetings from Research Society of Anesthesiology. Respected President Dr. Naveen Malhotra sir, past President Dr. Indrani Hemant Kumar ma'am, and all the dignitaries from Team Nagpur and all other dignitaries on the dais and off the dais. I congratulate the organizing team from Nagpur, Dr. Gauri and team, for this webinar. The success to any webinar is by active contribution of the speakers and the number of participants. We are already touching the house full. So I'm really thankful to all the faculty who will be deliberating today. I'm sure today's webinar will be quite enriching for the students, for the faculty, for the practicing anesthesiologists. Extend my all the best wishes to the faculty and the organizing team, Team Nagpur. Thank you very much, and long live the Research Society of Anesthesiology. Over to you, Dr. Shraddha, please.
Thank you very much, Vishal sir. So moving on to the main academic program now. We will start our sessions, but before that, let me introduce to you the eminent chairpersons who are going to moderate the entire session. We have three strong ladies out there who are going to mentor the entire session. Our first chairperson is Dr. Indrani Hemant Kumar ma'am. Dr. Indrani ma'am is the immediate past president, RSACP, and professor and head Department of Anesthesiology, Symbiosis Institute for Women, Lavre, Pune. Our second moderator for the session today is Dr. Anjali Bure, madam. Madam is professor and head Department of Anesthesiology, NKPS IMS Nagpur, and she is the past vice president ISA National. She's also been the past president of ISA Nagpur City branch. Our third chairperson for the day is Dr. Geeta Alawat ma'am, professor and head Department of Cardiac Anesthesia, PGI Rohtak. I welcome all of you, dear madams, and with your permission, can I announce the first session?
Yes, please do.
So our first topic for discussion today is the practical approach to perioperative hypertensive crisis in anesthesia, and our speaker for the same is Dr. Om Shubham Asai. Dr. Om Shubham Asai is Associate Professor, Department of Anesthesiology, AIIMS, Nagpur. Over to you, sir.
Good evening, everyone. I'm just sharing my screen. Can the host give me the access of sharing the screen?
Yes, sir. You have been made the co-host. You may share your screen.
Yeah, I'm just sharing the screen. Is my screen visible now?
Not yet, please. Yes, it is visible.
It is visible. Okay, and everybody can hear me.
Yes, yes.
Yeah. Good evening, everyone. My name is Dr. Om Shubham Asai, and today we'll be speaking on the practical approaches to the perioperative hypertensive crisis in anesthesia. Coming to the definition, what is the hypertensive crisis? It is any systolic blood pressure more than or equal to 180 mmHg or the diastolic blood pressure more than 120 mmHg, and it is of two types of the urgency and the emergency depending on the end organ damage, whether it is present or not. Its prevalence is 1 to 2% of the hypertensive patient.
I think he's frozen. Hello, Om. He
Yes,
has to.
Are you? Can you hear?
Hello, Om.
No, we cannot hear.
He's frozen. I think he has to
Yes.
log out and log back, I think.
Yeah, he's still logged in, ma'am. Can you please call him, ma'am? Gauri?
I'll do that. I'll do that.
Few members have reported in that the voice is not clear. Is it not clear to everybody, please?
His voice is very clear.
The voice of Dr. Asai was clear, ma'am?
Yes, it was clear.
Yes, it was clear.
It was clear, but he was just in his first slide and he froze from
Yes,
there.
ma'am. Yes. What is this happening, ma'am? Dr. Gauri, ma'am, if he's taking the time, then we can shift on to the next speaker. In the meantime, he can get his logistics clear, ma'am.
Can we take the second lecture by then?
Dr. Gauri, ma'am, have you had a word with Dr. Asai, ma'am? I think she must be in talk with Dr. Asai. We'll
I
wait
think we
for
should-
a minute.
Yeah.
What do you say, ma'am?
Or
Yeah,
we can
maybe
have the
just-
next speaker.
Yes, ma'am. Please take up the next speaker, Dr. Shraddha. Dr. Shraddha, am I audible?
Yes, sir. You're audible.
Please take up the next speaker, Dr. Shraddha.
Okay.
Can we take up the next speaker, please?
Okay. So till the time Dr. Om Shubham is clearing his technical glitch, we will take up the second lecture. Our second topic for today is intraoperative MI. And to elaborate on that, we have Dr. Shilpa Tivaskar, madam. Madam is a GC of Rsacp Maharashtra State Chapter. She's also a GC member, Society of Anesthesiologists Maharashtra State. And she's a senior consultant, Bhaktivedanta Hospital and Research Institute, Mumbai. We welcome you, madam.
Thank you, Dr. Shraddha. Thank you, thank you, Rsacp Nagpur City Branch and Dr. Gauri Madam for invitation. Thank you, Dr. Naveen Sir, Dr. Vishal Sir for the opportunity. I'll start sharing my screen. Yeah, is it visible?
It's visible, ma'am. Please go ahead.
Yeah. So intraoperative myocardial infarction, a dreadful complication. I had a case, 58-year-old patient, a obese class 2 patient with diabetes since 10 years controlled on oral hypoglycemic agent for tympanoplasty. Usually we do under local plus sedation, but since he had a history of snoring, short neck, we thought better to give general anesthesia. Preoperative pulse was 84, blood pressure 153/86, induced with pre-medication midazolam, nalbuphine, xylocard, and propofol cisatracurium, maintained on oxygen nitrous oxide sevoflurane. After induction, the pulse and blood pressure were settled. The surgeon prepared adrenaline preparation, half ampule of adrenaline in 30 cc of plain 2% lidocaine, that is 1 in 20,000. Usually 5 to 6 ml only of this is injected and rest is used in patting. So sir started first injection around the pinna and tragus, 1 ml, 1 ml, and next injection was into the auditory canal. Suddenly, in next 5 minutes, the pulse became 160, blood pressure 220/116. The oxygen saturation and EtCO2 were maintained. Since the blood pressure was more than 200 and pulse more than 120, we asked the surgeon to stop injecting and not start the surgery. I gave labetalol 20 milligram in 100 cc NS bolus over 5 minutes. Simultaneously, injection dexmedetomidine 10 microgram IV was given slowly over 2 to 3 minutes and sevoflurane dial concentration increased to 2.5%. The next reading was pulse 123 per minute and blood pressure Oh my God, it became 60/46. Had I overtreated it? I don't know. The oxygen saturation was 92. The peak airway pressure became 37. Now, naturally, the initial thought process, since I had given labetalol, fall in BP and hence fall in saturation. So wait till I give mephenteramine and again rise in BP. So I waited. Sevoflurane I switched off. Nitrous oxide was still on. Intravenous fluids I made fast since the BP was low. But why there was increase in peak pressure? So I auscultated the chest. There was spasm, rhonchi, creps. So I decreased the IV fluids. Oxygen concentration was made 100%. Was it anaphylaxis? But there was no dermal signs. And then suddenly, as I looked at ECG, I saw changes. I saw ST depression and T wave inversion in lead 2. And in our ECG monitor, usually we have lead 2 and one lead V. So ST elevation in lead V. So I had ST depression in lead 2 and ST elevation in lead V. If you see the next picture, in first picture, the ST depression is upsloping. In the next picture, the XT depression is still low. The upsloping has gone. Now, the pulse was 123, blood pressure fell more, saturation fell more, mephenteramine was given, noradrenaline started through peripheral line. Well-lead ECG was mobilized from the post-op area. Call for a 2D echo machine was done. Call for cardiologist. Surgery abandoned since it had not started. ICU informed and preparation for central line started. Now, what was our differential diagnosis? High blood pressure and high tachycardia. It caused decrease in diastolic filling of the coronaries. The coronaries fill during diastole. So naturally, what happens during tachycardia? The decrease in diastolic time and hence decrease in diastolic filling of the coronaries, which led to acute myocardial ischemia and infarction. Or high BP and tachycardia cause destabilization and rupture of coronary plaque, or it could be just an cardiogenic shock, which was overt, which became decompensated because of high BP and tachycardia, or an acute pulmonary embolism or anaphylaxis. And the ECG, if you see, there is ST depression in almost lead 1, lead 2, AVF, and you can see ST rising in V2, V3. So this was a STEMI. The 2D echo showed LVEF 30% and there was global hypokinesia. So my next 15 minutes will be how to suspect intraoperative MI, signs under general anesthesia, under spinal anesthesia, or any regional anesthesia. What supportive treatment should we start? Are there any investigations to be sent? What is the definitive treatment in mild, moderate, severe cases? What are the factors which predispose to intraoperative MI, the treatment of the case, how to prevent this type of cases, and the take-home message. The British Journal of Anesthesia has a beautiful article talking about the perioperative MI. What it says, it is uncommon, it is rare, but when it occurs, it is life-threatening. They compared 9 million hospitalizations, out of which in ASA1 patient, it was just 0.9%. So my patient was in that 0.9%. And if there is any predisposing factor, then it is 11%. Now, what is the pathophysiology? Why does this MI occur intraoperatively? There are some non-coronary causes, there are some coronary causes. Non-coronary such as pulmonary embolism or acute decompensation of heart failure or sepsis. Now, let's concentrate on coronary causes. Coronary causes can be of two types. The last thing, if you see, atherothrombosis, so it could be a thrombus, or it could be a plaque which has ruptured, or a thrombus which has acutely got blocked. But second, which most important, which lies in the hands of the anesthesiologist, is the supply-demand mismatch. Whenever there is tachycardia, the coronaries don't fill. Whenever there is hypotension, what happens? The diastolic blood pressure goes down. The coronaries fill in diastole. If it is less than 30 to 40, then there will be decreased filling of the coronaries. Also, the coronaries require oxygen, which is supplied by not the dissolved oxygen in the blood, but the hemoglobin, and hence anemia will also affect it. So remember, anesthesiologists have to match the supply and demand. So accordingly to the coronary cause of myocardial injury, there are two types of MI described according to the coronary cross. As I told you, rupture of a plaque, or type 2, where patient has stable coronary artery stenosis, which was not diagnosed, maybe say 50%, 60%, but it got decompensated. Myocardial ischemia occurred. Why? Because suppose not in this case, but in literature, there is a case where there was a spine surgery and suddenly there was blood loss ongoing and 2000 ml blood loss was there. So there was anemia, acute blood loss, and hence myocardial perfusion is impaired. It takes oxygen from the hemoglobin. Or if there is hypotension, then naturally the blood flow through the coronaries becomes sluggish. Coronaries supply themselves in diastole and increase oxygen demand, increase myocardial oxygen demand in tachycardia, hypertension. In hypertension, what happens? The heart has to pump against a high blood pressure in the aorta, and hence there is increased myocardial oxygen consumption. So we have to avoid all this, what is there in the hands of the anesthesiologist. Same here. So goals of treatment will be what? Maintain low to normal heart rate so that myocardial oxygen consumption is not increased. See to it that there is high oxygen content in the blood. The hemoglobin is achieved. Normally, they say in a cardiac case, it should be at least 10 gram%. In other cases, it can be up to 7 to 8 gram%, or special cases such as CKD, where we accept 8 gram%. Then high to normal aortic pressure. Why? Because the diastolic pressure decides the coronary blood flow. Reduced coronary vascular resistance should be there, and low left ventricular end diastolic pressure. If the patient has overt cardiac failure, then the patient should have received diuretics to decrease his end diastolic pressure. Also, same oxygen demand, how you decrease? Naturally, when the heart pumps faster, the oxygen demand is more. So decrease the heart rate, decrease the myocardial wall tension. How? By avoiding hypertension and excess fluid administration and avoid increased myocardial contractility. This is just type 1, type 2 differences. Now, how do I suspect MI under general anesthesia? Patient will not complain. So what? ST segment depression. Now, what does ST segment depression become? The coronaries supply the heart from the outer wall to the inner wall. So naturally, if there is any coronary block, plaque, or spasm, what will happen? The inside blood supply will be compromised. So there will be subendocardial ischemia. So remember, whenever there is ST segment depression, that means do not ignore it. First, we'll come to that. Then ST segment elevation. Remember, ST segment elevation at the J point, which is J point, where the QRS complex stops and ST segment begins. That point is the J point. If there is elevation of at least 1 millimeter, that is one small square at ST segment J point, then remember it is acute ST segment elevation, acute MI, which is started and which will evolve, and hence you have to act promptly. So new T wave inversions, again sign of ischemia. So remember, depression is a sign of ischemia and elevation is an acute MI. Q wave, there could be new pathological Q waves where a small part of heart is already started infarcting and evolving. Under general anesthesia, suddenly there is hypotension, there may be blood loss. You start pumping blood, you start noradrenal, everything, but the hypotension doesn't come up easily. Then suspect there could be myocardial ischemia. The heart has lost its power to compensate. Or there could be sweating under general anesthesia. And there could be decreased oxygen saturation can occur because of hypotension, or there could be because of decompensation of failure. Under regional anesthesia, what is extra? The patient will complain, restlessness, chest discomfort, chest pain, or breathlessness, shortness of breath. Remember, ST elevation is not good, so keep a watch on that. Also, under spinal anesthesia or regional anesthesia, patient will complain of nausea in addition to other symptoms. Now, for the anesthesiologist, is it significant to understand ST segment depression? Yes, because you are the one who is going to order for a 12-lead ECG. So ST segment depression could be upsloping, or it could be downsloping, or it could be horizontal, as you see. So upsloping is not important. The downsloping and the horizontal is important. The horizontal or downsloping ST depression of more than 0.5 millimeter at the J point in 2 consecutive leads indicates myocardial ischemia. So remember, On your screen, when you see ST depression, which you feel is significant, which you can appreciate on the monitor, then order for a 12-lead ECG and see that it is more than 0.5 millimeter. So that is just ischemia. But what says it's something more than ischemia? If the ST depression is more than 1 millimeter, and if the ST depression is more than 2 millimeters in 3 leads, then the patient is having myocardial infarction, and it is non-STEMI, non-ST segment elevation myocardial infarction. Mortality is very high. You need to act fast. Upsloping ST depression is non-specific. The first one, where you have upsloping, it is non-specific for ischemia. A very important thing, ST depression is seen, then you change the leads and see. If you, or you take a 12-lead ECG. If you see ST depression in most of the leads, then be assured it is just a subendocardial ischemia which you have to treat, but it is not a fully evolved infarction. But if you see ST depression in localized area, if you see right of my screen, I have said yellow color, occur yellow, lead 2, 3 AVF. They represent what? Inferior leads, right? Or the green ones, 1 AVL, V5, V6, they represent the lateral leads. So if you see ST depression, not in all the leads, or anyway, lead 1, 2, 4, 5, no, if you see in specific leads, say lead 1 AVL, V5, V6, if they have localized, then search for somewhere acute myocardial infarction is occurring, search for STEMI. I hope I'm able to convey what I want to. So see here, ST depression, you can see in 1 AVL and V5, V6. And here in AVR, you will see a slight elevation of ST. So when it is specific, you see elevation. Similarly in this, of course, we take the help of cardiologists to diagnose. But once the 12-lead ECG is in our hand, you will see that ST depression is there in 2, 3 AVF. And AVL, if you can appreciate, at J point, there is small ST elevation. Now coming to T wave inversion. T wave inversion, it is significant if it is at least 1 millimeter deep, present in 2 consecutive leads. And remember, see the last line. T wave inversion is only significant if seen in leads with upright QRS complexes. Okay, T wave inversion is a normal variant in leads 3, AVR and V1. Again, for T wave inversion, it could be of 2 types. If you see the first figure, then it is biphasic, right? It is upright and then downstroke. So biphasic. If you see the next picture, the entirely it is deep symmetrical. So deep symmetrical T wave is a sign of infarction. There is severe ischemia and infarction. So what are non-specific? Now we saw some specific changes. Now let's come to some. So T wave, we saw that it should be at least 1 millimeter deep in consecutive 2 leads and with positive QRS. ST depression, we saw that more than 0.5 millimeter at the J point. Now what is non-specific changes? ST depression, which is less than 0.5, T wave inversion less than 1 millimeter, or just T wave flattening, or the ST depression, which is up sloping. So these changes you can ignore, but maintain normal physiology. Again, there are some classifications for the people who want to learn in deep about this. Of course, vital signs, you find the shock index, the heart rate versus systolic blood pressure. Then you see the echocardiography, the focus, the lung ultrasonography to see if there is pulmonary wedge pressure is increased, B lines are seen, and the classification. So severely reduced LV systolic function. When you do a 2D echo bedside, it suggests that patient will not respond much to beta blockers. Now, so we have all this data information. What is the universal definition of myocardial injury or infarction? Troponin concentration above 99 percentile. It is very important. Recently, I had a patient who was for the cerebellar bleed, okay, 50-year-old non-hypertensive, non-diabetic, and he had troponin I increased, CPK-MB increased, and ECG changes. So we were confused whether that troponin, he had a primary cardiac event and hypertension and then bleed. So remember, troponin still can be increased if the patient is unwell, and hence the definition has come that concentration should be, at least one reading should be above 99 percentile. So troponin increased, myocardial infarction, a rise and fall in troponin concentration. Symptoms should be there of ischemia. If the patient is under GA, new ischemic changes, pathological Q wave, and imaging. When you do sonography, there should be fresh regional wall abnormality or low EF or some myocardial compromise. Now the treatment goals in next 10 minutes, the treatment goals, you have to pause the surgery, right? Confirm the diagnosis. Normal heart rate, as we all discussed, that increased heart rate will decrease the coronary filling. Normal blood pressure, so that heart does not have to pump against high blood pressure. If it's low, treat it. Oxygen saturation, sugars should be normal and temperature should be normal. Administering medications such as beta blocker, caution of course in patients with heart failure and COPD, and nitrates to improve the coronary blood flow, of course if the BP permits. Fluid resuscitation. For pain, we give opioids. For reperfusion therapy, we'll see when to take the patient for reperfusion. If patient is for bipolar hip replacement, or then whether we can immediately take for reperfusion. And what you have to send, NT-proBNP, which defines if there will be pulmonary edema, the lactates, when there is low BP, electrolytes, magnesium, ABG, baseline cardiac troponins. Why? Because cardiac troponins take around 2 to 3 hours to rise, and hence, but we have to find some baseline and then repeat after 4 hours. Same supportive treatment. What are the goals? They say that maintain oxygen saturation above 90%. Nitrous oxide is not harmful. You can continue. Maintain systolic blood pressure above 90. Maintain hemoglobin at around 10 gram%. Use all the drugs, cardiac specific drugs to decrease the heart rate, metoprolol, esmolol, or you can use the anesthesia drugs, dexmedetomidine, xylocard, to decrease the heart rate. Avoid giving COX-2 inhibitors for pain. They have prothrombotic. Avoid using NSAIDs for pain. If there is chest congestion and BP permits, after starting non-adrenaline, you can give furosemide bolus or infusion. Cardiac troponins, they behave like this. If you see, then in other situations such as PE, that is pulmonary embolism, and marathon runners, there is no second rise. But in STEMI and non-STEMI, there is a dip after a few hours. After 3 to 4 hours, there is a maximum rise. There is a dip, and then again there is a second rise. Again, same. Okay, now apart from this case where the surgery had not started, we took the patient in cardiac cath, we did angiography, we could do stenting also. But suppose the patient was fracture femur patient for PFN, intraoperatively shortness of breath, ECG changes, then what? Or a patient with sepsis, laparoscopic cholecystectomy is going on for empyema gallbladder, and you see the changes, then what? Or subdural hematoma evacuation, and you see VPCs and changes, then what? Such situations, you cannot totally stop the surgery. You can pause the surgery, do supportive treatment. Now we are discussing something where high bleeding risk is there and STEMI has occurred. Okay. STEMI is ST elevation has occurred. So pause the surgery, supportive treatment, and then finish the surgery. Supportive treatment is maintaining pulse, blood pressure, oxygen, sugars, and temperature. Some cases where cases intraoperative MI is reported, they have given through Ryle's tube, they have given antiplatelets, but in some cases, what has happened? Bleeding has occurred from all the sites in those patients. So it's better that no antiplatelets or unfractionated heparin or LMWH is given on table when there is high bleeding risk. Now, the new modality, what we had 25 years back, it has come back. Post-operatively, you can just do balloon angioplasty without putting a stent and use rapidly reversible IV antiplatelets. And after third day, start dual antiplatelets. And later on, do a proper, I'm so sorry, I said balloon angioplasty with stent, sorry, balloon angioplasty without stent And later on, after 4th, 5th day, you can go for a proper treatment with percutaneous coronary intervention, that is PCI. So when there is high bleeding risk, do not give anything on table. Just take to cardiac cath. If there is STEMI, if there is non-STEMI, then do medical treatment only. If there is STEMI, take to cardiac cath and do balloon angioplasty. What are the reversible antiplatelets and reversible antithrombin drugs, which the cardiologist will start? The tirofiban or abcipzimac is started, which will return platelet function in 4 to 8 hours, or ticagrelol is given, which will return in 60 minutes. The newer drug which is used now is bivalirudin, which will take the function back, the thrombotic function back within 1 hour. So this we can use when the patient has STEMI but high bleeding risk. So this is the management where whatever we talked till now is divided into high bleeding risk. Then there is something called as bespoke protocol 1, which you followed within first 24 hours if there is STEMI. If it is not STEMI, then bespoke protocol 2. If there is no high bleeding risk, no only minor changes, then follow the NICE guidelines after 48 to 72 hours. Now, what is this BIS protocol? Another last 5 minutes. So this protocol where don't give any immediate aspirin, clopidogrel, short-acting antiplatelets, which can be reversed, can be given. Consider balloon angioplasty only if there is STEMI, and defer proper treatment with stent, that is PCI intervention you defer. Follow up with aspirin ticagrelol once definitive procedure is undertaken, and peri-procedural heparinization if required. Again, protocol 2, where their bleeding risk is less, but if there is STEMI, then you take the patient for immediate percutaneous coronary intervention, and short-acting antiplatelets are given, follow up with aspirin and ticagrelol. This is same with low bleeding risk, go for primary percutaneous coronary intervention. But remember this, that even if don't be happy that we are doing primary cutaneous coronary intervention, so patient will be all right. Remember, even it has pitfalls in emergency. If there is an in situ disease or there is a ruptured plaque, then it may not always give good results. This is again, okay, if you have left the surgery halfway and you are waiting to do angioplasty on 3rd day, remember, if you have to complete the surgery, if you take the patient again, then finish the surgery. And then, because once you put a stent, you will have to wait for so many days. The risk factors, of course, we always take precaution in these patients: poor cardiac status, diabetes, hypertension, smoking, periop. What they have found, the most important factor which can cause complications is perioperative hypotension. So remember, in any ASA1 patient also, please maintain the systolic blood pressure above 90 and the mean above 65. Again, the NICE guidelines, which say the same, when to do medical management. If the patient is stable, no further STT changes, no enzymes, then go with ticagrelol. If you feel low bleeding risk, then go with primary coronary intervention. If not, there is a bleeding risk, then go with the third section, that is fibrinolysis. This is for non-STEMI. So my take-home message is what? Maintain normal physiology intraoperatively, whether ASA1 patient or ASA4 patient. See to it that the cardiac oxygen supply is not decreased. So coronary blood flow is maintained, diastolic blood pressure is maintained, the heart rate is not high, and do not increase cardiac oxygen consumption by tachycardia or hypertension, right? Be vigilant for STT changes. Do not ignore them. Whenever in doubt, take a 12-lead ECG. If you're not sure, ask the cardiologist, ask your colleagues, and act immediately to salvage myocardium and the patient. Thank you very much for your patient hearing. I hope I did justice to the topic. Thank you for the opportunity, Dr. Gauri Madam and Naveen sir. And
Thank you, Shilpa Madam. You have really simplified and made it look as simple as that. And it was very elaborate and very informative. And thank you so much for that presentation. I think we'll take questions for all the three speakers in the end. And I think if Om sir is ready with his presentation, we'll take up the first lecture of management of hypertensive crisis. Dr. Om Shubham Asai, please.
Yeah, I have just joined. Yeah, just joined back. So we will just start the lecture again. No
Yeah.
issue. Can I start it now?
Yes, you can
Yes,
start.
Yeah, I have just sent a request for sharing the screen.
What is your ID, sir? By what name you have joined?
Om Shubham Asai.
Oh, just
I think I got the access. I'm
yes,
just.
yes. Just wait, sir. Just wait. Please go ahead, sir.
Can you see my presentation now?
Not. Yes, please on your PPT.
Yeah, and now you can hear me clearly.
No, you are audible, but your PPT is not visible yet.
My presentation is not coming.
Yes,
Okay,
please. It is now visible.
yeah, just 1 minute. I will do again it. Is it visible?
Yes, you are audible, sir. Plus, I mean, share your screen, please.
Yeah, is the presentation visible?
No, it's not visible to me. Is it
not
visible?
visible, sir.
Yes, it is
now.
visible now.
Now it
Please.
is visible.
Please go ahead, sir.
Yeah, now it is visible, right?
Yes, sir. Please.
Yeah. Good evening, everyone. Today we'll be talking about the practical approach to a perioperative hypertensive crisis in anesthesia. So going to a definition, any systolic blood pressure more than or equal to 180 or diastolic blood pressure more than or equal to 120 over 80, we call it as an hypertensive crisis. It is of two types, urgency or the emergency, and depends on the end organ damage. Its prevalence is 1 to 2% of the hypertensive patient, and it do have and significantly impact on the anesthesia outcome. So if you see what is an hypertensive emergency is the one where your BP is satisfying the hypertensive crisis criteria, but it is associated with the end organ damage. On the other hand, if you see the hypertensive emergency, it is having the same BP criteria, but there is no organ damage. On the other hand, if you see, this is the AHA classification 2017, what they have told, they classified the hypertension, but don't go on the table. I just want to tell you ki for the elective cases, what is the BP, at what BP we should actually defer the case. So the literature what said any systolic or the diastolic blood pressure that is less than 180 by 110 mmHg. So you should actually not defer such elective cases because there is no change in the morbidity or mortality of such patient. Only if the BP is controlled with a medication. However, if the BP is more than 180 by 110 and the BP is not controlled by medication, then it is the time that such elective cases should be deferred from the surgeries. However, in case emergency, the scenario is something different that we cannot cancel the cases even if the BP is more than 110. So how to manage cases that we will further. So what will be the red flag and the operation theater and the PSU? The clinical symptoms like the chest pain, the shortness of the breath, and the neurological symptom, which might be confusion or the anxiety. Other signs you can see a kidney, oliguria, or the confusions. Now, what will be the common cause? It might be due to an inadequate depth of anesthesia improperly or due to pain, or it might be because of the drug withdrawal or a very clinical syndrome called a thrombocytoma crisis. There are other factors also, like the patient factor and the hospital factors. The patient factors are like the uncontrolled hypertension, clinical conditions like room overload, the pain, anxiety, and the autonomic dysfunction, and the biological response, which we see intraoperatively because of the release of the catecholamine and the corticosteroid. The other hospital factor, most commonly, we know that inoperative P measuring technique. The other factors are sleep deprivation, the acute distress, which might be due to pain, anxiety, or the fever, or using of a BP raising medications like an NSAID, stimulants like caffeine, cocaine, corticosteroid, erythropoietin stimulating hormone, and the herbal supplement. And the change in the medication used from the own environment, like we discontinue certain antihypertensive and we add certain new agents to manage the BP. So if you see, many patients will be already diagnosed with hypertension when they comes to an either urgency or to an OT, and they might be on certain drugs. So what is the actually guidelines telling what we should do? If the patient is taking already an ACE or the ARB inhibitors, the guideline to hold 24 hours operatively and to restart within quarters of the operation. Why? Because it is associated with a profound refractory hypertension, which might not respond to our regular vasopressor, what you are using. The other is the thiazide diuretic and the calcium channel blocker, which should be continued even on the day of the surgery. The loop diuretics, the literature says that either you can stop one day prior to surgery or you can even continue, depending on what type of surgery it is going on. Beta blocker, yes, it is recommended to continue it perioperatively. That is on the day of the surgery, even after operation, you use beta blockers. The preoperative blood pressure values may be used to define preoperative blood pressure and not blood pressure that we see on the OT table.
Dr. Asai,
So
sorry
coming,
to
why
disturb
this
you.
hypertensive crisis
Dr.
is
Asai, sorry
dangerous?
to interrupt you. Your slides are not moving.
Yeah.
Is it the current slide we are seeing here is
I
patient
am moving the
factors?
slide. Now it is moving.
No, it's not moving.
Now my
actually.
slides are moving. I am moving it.
No, it's not moving.
Just
Is it not visible to everybody or just on my side?
He's on patient elevated
now it is
BP reading,
moving.
patient factors.
You are on
Yeah,
elevated BP reading.
just move it
Yes,
now,
this
sir.
is visible to us.
Please move your slide, Dr.
You are
Asai.
seeing now why hypertensive. You are seeing the
Just move
slide
your
of why
slide, sir.
hypertensive crisis is dangerous.
No.
No.
Yeah.
Yeah, move. One more.
Okay.
One more
Okay.
slide.
Because I
We
am
heard this. We
checking.
heard this one. We heard this one.
What I am showing now.
Yeah, we heard this one about ACE inhibitors and ARBs.
Okay, but I am on the next slide, ma'am.
Dr.
On
Asai,
the
do you
next
have
slide.
this
Yes.
PPT in
You can
on
see
your
the slide.
WhatsApp? Dr. Asai, do you have this PPT on your WhatsApp?
No. I am using it on my laptop. I am
No,
connected to an
I
internet.
understand
I am
this.
using
I
on
mean,
my laptop.
if you can forward your PPT to somebody else, even if you can forward it to me, I can play it on your behalf. Probably there is some.
Okay, fine. I will just do one thing. I will put on a Gmail. Okay.
Please.
Actually,
Or you
we
can
will
Can
be
I get
moving the
your email
slide.
ID?
It's vishalksingla@gmail.com.
I think now it is moving, Dr.
It is moving now.
Please move on. Please move, Dr. Sai. Please move your slides.
Okay. Just
We are
moving
seeing
on.
this why hypertensive crisis is dangerous.
Yeah.
Okay, please carry on.
Yeah, 1 minute, just because I am not now able to see my slides. Okay, just 1 minute.
Or you can, play it like this only.
I'm just sharing screen one more time. Now you can see.
Yes, we can see, but it is not in
Yes,
the
I'm
PPT.
changing the slide now. Yeah, I know it is not in full screen. I am purposefully not keeping it in the full screen.
Okay,
Now it is
doesn't matter.
fine.
It is now we are seeing this why hypertensive crisis is dangerous.
Yeah, right.
Okay, carry on, please.
So shall I start? Yeah.
Please.
So now why this hypertensive crisis is very dangerous. Now, if you see this graph, if you see the optimal blood pressure range is very narrow, and actually in the literature it is not defined. It will depend on the individual preoperative parameter of the patient. But if you see this autoregulation curve of the organ blood flow to a wide range of the blood pressure, you can see that the organ blood flow is maintained. But however, if you see the probability of the mortality and the morbidity, if this increase or decrease in the probability of the mortality and mortality increases drastically. On the other hand, the same with the pressure autoregulation. Above certain BP, if the blood pressure is then your organ blood flow also increases, and this might lead to end organ damage. So if you keep this hypertensive crisis untreated, your mortality increases by 79% by 1 year, and your risk of stroke, myocardial infarction, renal failure, aortic dissection, that is actually the end organ damage, is also increases. So treatment is rapid, but not very rapid. Control of the blood pressure reduction is required. The next slide, how initial preoperative management you should do. Assessment is by an ABC, that is airway, breathing, and the circulation. Confirm BP manually by taking in all the 4 limbs. For example, like rule out aortic dissection, coarctation of aorta, where you can see an upper body hypertension, chest organ dysfunction, that I will tell you how to see in the next slide. Rule out reversible causes, we have already discussed. initiate monitoring, either you can use non-invasive or the invasive, but invasive becomes a class 1 indication when you are having a hypertension and there are chances that this patient might go into hypertensive crisis and might need an intravenous treatment antihypertensive agent. And you can consult that physician or an ICU for an further multidisciplinary approach. Now, these are the signs of target organ damage. The brain, actually, it will give us symptoms of an confusion, headache, visual changes, and the ECG. In case of heart, the patient might experience chest pain, and the ECG changes will be seen with an elevated troponin. In a lung, because of the back pressures, the patient might develop pulmonary edema and dyspnea. In kidney, the patient may experience AKI, resulting in oliguria and increased creatinine. And in retina, we see a papilloedema and the changes. These are actually the end organ damage, what you can see in the patient. What will be an intraoperative BP target? According to the guideline, we should actually not fluctuate more than 20%. Some literature says more than 30%, anything acceptable. So here we have already written MAP reduction is 20 to 25% over 1 to 2 hours, taking into caution that the systolic blood pressure do not drop below 120 mmHg. There is certain exception to this that I will explain further. Diastolic blood pressure range. Hello, ma'am. अभी भी नहीं है? Okay, 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 okay. My is not.
I don't see your slides now, sir.
Is my,
So can you double click on your slide?
my slides are not moving.
Yes, can you go to individual slide and double
But
click
you
it?
can hear me. My slides are not moving.
Dr. Om Shubham, can you please go click on the button slideshow near this home button?
Okay, okay. Let me do it.
Can you please click on the slideshow
Yeah,
button?
now
There, will you please guide it?
still my slide is
audible?
not visible or what?
It's not moving. It has moved. The next slide. Yes.
Its ninth slide is there.
And
The
am I
slide
audible?
is-
You're
You are
audible.
audible.
Yeah,
You're
and now
audible.
you can see a slide
Yes,
of
now they're
intraoperative
moving.
BP
Now
targets.
they're moving. Yes.
Okay, okay. I'm just moving a more to and more good network area. I think I have some problem with the network connection. Now you can see my slide properly, no?
Yes.
Now
Yes.
it is
Now
moving.
your
Yeah.
slides are moving.
Okay, okay, fine. Shall I continue further?
Yes.
Please go ahead.
Okay. So now let me speak about the intraoperative BP target. The target is about mean arterial pressure reduction of 20 to 25% over 1 to 2 hours. And then slowly over the next 24 hours, you can a target of 5 to 10% of decrease in the blood pressure. But taking into caution not to drop the systolic blood pressure less than 120 mmHg. There is one exception to this, which I will explain you in the next coming slide. The diastolic blood pressure range can be 90 to 100, and the systolic blood pressure range should be 140 to 160 mmHg. Maximum, the mean arterial pressure should be more than 65 mmHg. But in case of chronic hypertension, this can move on depending on how is the autoregulation set. So coming to how we should manage the hypertensive emergencies either in the OT or in the emergencies in the perioperative period. But before coming to that, I just want to show you these two tables from the Miller. So just focus on my this pointer, what I am showing. Just focus on the patient is having hypertension and tachycardia. The first thing what the Miller says is check the depth of the anesthesia. The second, he also will advise to give an intravenous beta blocker to control the heart rate. And then you can give an intravenous vasodilator like NTG he has given for the hypertension. But in case if the patient is having hypertension and the normal heart rate, then he doesn't advise us to give an beta blocker. You can just give an vasodilator, and along with that, you can check the depth of the anesthesia. So our entire treatment will be for rotating around this thing only. So the parental drugs, what we can use for an hypertension, there are a lot amount of agent. You can use a labetalol, a metoprolol, an ismolol, or there are nitroglycerin, the sodium nitroprusside, hydrolyzing. Okay. So when you should use this under which condition? Like if the patient is having acute coronary syndrome or intracerebral hemorrhage or encephalopathy, then labetalol is actually the drug of choice. In case of stroke and renal failure, nicardipine is the drug of choice. And for aortic dissection and tachycardia, ismolol is actually the drug of choice. management of the hypertensive emergencies, these are actually the end organs like the brain, the artery, the retina, the kidney, and the heart. What exceptions I was telling is the arteries. If you see in the patient with an acute aortic dissection, STEMI, and acute heart failure, the target systolic blood pressure is less than 120 mmHg, which is not in other this thing. Other, they have only told that maximum 20% or you can accept 30% reduction in the blood pressure from the baseline. But that doesn't hold true in this case of arteries. Additional agents, as I already told, now nitroprusside, which we can use in congestive heart failure and surgical hypertension, the glyceryl trinitrate used in pulmonary edema, ACS, and hydrolyzin, which is preferred in pre-eclampsia or eclampsia patient in the pregnancy. Now, special surgical scenario, I already told in aortic dissection, the target heart rate is less than 60, systolic blood pressure less than 120, and you can use ismoral plus nitroprusside. Neurosurgery, the most important thing is maintain cerebral perfusion pressure. Why? Because the formula is the mean arterial pressure minus the intracranial pressure. Sometimes the patient might have an IC bleed, which can actually block the normal CSF flow, and that can increase the ICP. So in that case, if you drastically decrease the BP, then that it's recommended. It can compromise the cerebral perfusion pressure. That's why it is very important in neurosurgery to decrease the BP very slowly and to maintain the cerebral perfusion pressure. The other is the clinical condition scenario of pheochromocytoma, where the patient is already the preferred agent of choice is an alpha blocker, that is phentolamine. So pre-op also the patient will be on phentolamine. Intraoperatively, if there is some hypertensive crisis, the drug of choice is always the phentolamine. After the tumor is removed, sometimes the adrenaline rush will come down. The patient might have hypotension. Then we might require sometimes non-adrenaline to maintain the BP. The other is post-operative monitoring after the surgery, what we have to do. The most important thing is resume antihypertensive agent. That is most important. If you don't resume it after the surgery, the patient might have a rebound hypertension also. So as I already told, AC inhibitors within 48 hours, you have to resume. Beta blocker, you have to give on the day of the surgery. Calcium channel blocker, diuretics also, you can continue on the day of the surgery after the surgery is over. Avoid fluid overload. Monitor vital labs, most commonly urine output, creatinine and troponin level. Sometimes the patient is done under regional anesthesia or the patient is not catheterized and the patient is having full bladder, that can also lead to an hypertensive crisis. Now, how the management summary goes on, depending on what is the targeted BP and what are the end organ damages the patient might be having. Upon that, our drug selections might be there. Then we have to monitor side effect of what the treatment you are giving. Watch for bradycardia, tachycardia, synapse toxicity, which is more common with nitroprusside. And continuous infusion is prepared because whatever amount of emergency intravenous antihypertensive agent we have, many of them have very short half-life. So we have to give loading and we have to keep in maintenance till the target BP is achieved. And once that target BP is achieved, then we try to shift it to an oral antihypertensive agent with bridging with that of an intravenous.
Dr. Om, you're not audible.
Challenges in the hypertensive emergency care. What is the rapid BP reduction risk? There might be ischemia due to hypoperfusion, or there might be a worsening organ injury. Individualized treatment, that is adjust based on the organ damage and balance BP and the perfusion, as I already shown with the graph. There is a very narrow range to maintain the BP. Now, this is just one case scenario. That is a presentation 70-year-old male with an BP of 200 to 120 comes with a confusion in an PSU. Confusion means already he is having a neurological, some insult to the brain. But after assessment, you see that the creatinine is elevated, ECG, so ischemia. That is, he is having multiple organ dysfunction. So what will be our management? Our management will be the same. You try to decrease the BP, but not more than 20%. And you can use anything, but here we will use IV labetalol to reduce mean arterial pressure by
I have the
20%.
light, but I don't have electricity to charge. But I can log in through my mobile, but then 100 people are
Stabilize and transfer to the ICU. So these are actually the evidence-based insight on what this presentation was made and what we have to do and not do in the management. Like do rule out the secondary causes of hypertension, titrate IV drugs slowly and ensure adequate perfusions. Don't avoid sublingual nifedipine and don't normalize BP abruptly. Yeah, it should be done rapidly but not too fast. Otherwise, it will compromise the perfusion of the other organs. The key points on hypertensive crisis is preoperative threat. Yes, hypertension is always called a silent killer. So hypertensive crisis can complicate surgery. Organ damage is very critical, so it is very important to preoperatively rule out all the organ damages. Targeted IV needs. Yes, in case of any perioperative hypertensive emergency, we have to target what medications we have to give depending on the scenario as we are already discussed. And you should always balance speed and the safety. That is, avoid rapid BP drop that can actually harm the patients. Thank you. Now I think there was no problem in the slide sharing and the communication.
Yeah, it was perfectly okay, Dr. Sai.
Okay, I have slightly moved to a better network. I'm sorry for that.
Doesn't matter, doesn't matter. Please.
Yeah. Thank you. I think my slides are over now.
Thank you, sir. Thank you so much for that elaborate and informative lecture. We will take all the discussions and questions after the third lecture together. So moving on to the third and the concluding lecture or talk in this series. This is common intraoperative arrhythmias, the diagnosis and management. And to throw light on this very important topic, we have with us Dr. Ridhima Sharma, Associate Professor, Department of Anesthesiology, AIIMS, Nagpur. Dr. Ridhima, ma'am, please.
Good evening, everyone. Is my slides visible?
Yeah.
Yes.
Yes.
They're visible, no?
Yes.
Yes, ma'am, please. Visible, ma'am, please go ahead.
Yeah. They're moving now.
Yeah, they're moving.
They're moving.
Can you make them full screen though, ma'am?
From my side, it's full screen. It's not.
No.
Ma'am, there is a
I use slideshow maybe.
no, actually there is a button on the top, ma'am. Use slideshow.
Use slideshow, the top button, ma'am.
On the top, ma'am. Top, ma'am.
Left corner.
Top, madam.
Top
Yeah.
left corner, ma'am.
Yeah. One second.
Yeah.
Yes, ma'am.
Yeah. That.
Yeah. So, good evening, everyone. At the outset, I would like to thank Gauri ma'am and State Nagpur branch for having me here. And I express my gratitude to Naveen sir, Vishal sir, Indani ma'am, Anjali ma'am, and Geeta ma'am. Their zeal of working for academics is contagious, and I hope we do justice for that. So I'll be talking about the common intraoperative arrhythmias, diagnosis and management in the perioperative period. So to the disclaimer that in the next 20 minutes, I'm not sure that you can become an ECG expert, but I'm sure that you will be able to recognize the most warning signs of on your monitor and treatly promptly. So I'll be talking about diagnostic tool and their common types of arrhythmias, their management strategies and case studies. So what is arrhythmias? Arrhythmias are the abnormal heart rhythms caused by irregular electrical activities. In life also, if you walk too fast or too slow, it is not normal. So like the way it is. So by definition, it is abnormality of the cardiac rate, rhythm or conduction, which can be either lethal, causing sudden cardiac arrest, sympathetic or symptomatic, including syncope, near syncope, dizziness, palpitation, or can be asymptomatic. So most common cause of cardiac arrhythmias has been grouped as damage to the conduction system, reentrant circuit causing abnormal impulses, abnormal atomicity of the heart muscle cells, ion exchange, and ectopic foci generating extra beats. So coming to the stats, we just see that the most 30% of the incidents occur in this, and most of the cardiac arrhythmias in the perioperative area is supraventricular 90%, and but not to the less 15% are the ventricular arrhythmias. As we know, that all of us know that the cardiac patient are definitely at the most higher risk of arrhythmia. So there's always a raise alarm when you're taking a cardiac patient for a non-cardiac surgery. So there has been many factors that have been included for the perioperative arrhythmias. They are patient concern, anesthesia concern, and definitely the surgery. Coming to the patient with the intracranial diseases, including subarachnoid hemorrhage, shows the ECG abnormalities, and very soon, if not promptly treated, goes to life-threatening arrhythmias. old age, geriatric age group is very important because of the aging. There is a degenerative changes in the atrial anatomy, which can cause them prone to the atrial fibrillation, and especially in the post-operative period. In the era of when we are falling, this rapid discharge, we should be, and daycare surgeries are increasing day by day. We should be very aware when we are discharging our old patient, because they can immediately throw into atrial fibrillation. So post-operative period is equally important as our intraoperative period. Coming to the anesthesia concern, tracheal intubation is a very important cause where it can cause hemodynamic perturbation, and because of that, if patient can throw arrhythmias, especially during when there is a light plane of anesthesia, hypertension, tachycardia, hypoxemia, hypercarbia, exogenous epinephrine, and aminophylline drugs can also go on. Nowadays, we are not using halothane, but previously, the halothane and fluorine were considered to be very arrhythmogenic through the re-entrant pathway mechanism. So no doubt local anesthetic nowadays, with the easy availability of the ultrasonography, and pain is considered one of the most important factor to take care in for the perioperative physician. Local anesthetics has been used very widely. So we should be aware of their toxicity also, especially they call sympathectomy and the parasympathetic system bradyarrhythmias are very important. Initially, when there was, now it has become like a routine for the postgraduate to check for the airway difficult card. Now is the time when we should also make a life-threatening card for the local anesthetic, considering all the intralipid and consideration of arrhythmias. Central venous cannulation, all the anesthesiologists have witnessed, especially in the right atrium. And initially, I remember when we learned central line venous cannulation by blind technique, when we used to see the arrhythmias, then we were confirmed that we are in the vein. But nowadays, with the advent of the ultrasonography, definitely the risk of arrhythmias has decreased, but not eliminated. Electrolyte imbalance is very important during the perioperative period. Abnormal ABG should raise your eyebrows whenever you are taking such patient. So especially when the patient you are taking from the ICUs, in our scenario, we have most of the patient who comes for the debridement and the amputation and from the ICUs and plastic surgeries, and especially the chronic ill patients who have been not fed from long time may shows electrolyte imbalances, and it should be taken care. Why we are talking about these factors? Because these factors are modifiable, and if you take an extra caution, we can prevent the patient from landing up into the any of the complications. Surgery, definitely cardiac surgeries, patients are more prone to it, and non-cardiac surgery coming, we have a vagal stimulation, especially peritoneal abdominal surgeries. And these are mostly focused when you must have witnessed a lot many times when trocar is introduced during the laparoscopic surgeries, there is a sudden brady and we have to shout the surgeons to decrease the pressure or do it very lightly. So direct pressure on the vagus nerve during carotid artery surgery. Oculocardiac reflex, especially in the ophthalmic surgery, when they put traction on the medial rectus muscles, there is a cause of bradycardia, AV systole, and most of the literature in some of the literature they have also witnessed asystole during this eye surgery. So you go anywhere, but the 5H and the 5Ts you need to remember by heart. If you cannot remember it, by the time you can put it in your OT tables. Hypovolemia, hypoxia, acidosis, hyperkalemia, hypoglycemia, hypothermia. Tension pneumothorax, tamponade, toxins, coronary thrombosis, pulmonary and unrecognized trauma. These are the causes of the cardiac arrest, and these causes are reversible. Never treat, our senior used to say, never treat the lab, treat the patient. Likewise, never treat the rhythm of the ECG, treat the cause. So before you jump into the final treatment, please find out the cause of your perioperative arrhythmias before you proceed further. So whenever you go for an ECG strip, you need not to be very expert, but the 6 things you need to ask. What is your heart rate? Is the rhythm regular or not? Is P wave and QRS complexes are normal, or P is followed by the QRS complex? And the rhythm is dangerous or not? These are the 6 questions that you need to answer during your perioperative period. So coming to the broader classification of the this arrhythmias, there are bradyarrhythmias and tachy. And as the both names suggests, if the heart rate is less than 50 and the heart rate is more than 150 respectively, they are considered as brady and trachyarrhythmias. In the brady-trachyarrhythmias, the most common sinus bradycardia, and then they're followed by first degree, second degree complete heart blocks. And tachyarrhythmias can be broadly divided into narrow and wide. Even if you are not very expert in ECG, just see the QRS complex. If it is less than 0.12 a second, it means it's a narrow QRS complex. And if it is more than 0.123, approximately 2.5 boxes, it is a wide QRS complex. So we have this sinus tachycardia in that atrial premature beat, atrial tachycardia, flutter, and fibrillation. And the white, we have ventricular premature beats and extrasystole, VTAC, VFib, and torsade pondus. So whoever anesthesiologist stuck with this arrhythmias has, this reminds me of the picture of the Ravana. In ancient times, we have 10 hands and 10 heads. That may be the possible, but not now. So in the modern area, you need, whenever you are witnessing a perioperative arrhythmia, so alteration in your rhythm, you just call 10 hands, but specifically one leader. That is very important. You cannot have 10 minds and 10 hands. So leadership is important. So you need to be very comprehensive and you need to hold your tachycardia first and then your patient's tachycardia. So intraoperative arrhythmias, as far as concerned, they are broadly supraventricular, as we have already told in the broader classification: sinus tachy, bradyarrhythmias, proximal tachycardia, fibrillation and flutter, and ventricular premature ventricular contraction, tachycardia, fibrillations. And the nodal. So coming to the most common is the sinus bradycardia. It is the heart rate which is slower than expected for age. Normal P, QRS and T complexes are there. So the most common causes you have to rule out is the hypoxia, vagal tone, hypothermia, hypothyroidism, drugs, and hyperkalemia. So before you jump into pharmacology, you need to rule out these causes. Is that the cause is reversible? If the cause is reversible, first is the cause before you treat the bradycardia. So mostly you have to find out, there are physiological causes also, like athletes or, resting heart rate is very important to know before in a pre-op area of your patient. Secondly, in the patient with the coronary artery disease or, ischemic heart disease, this extreme sinus bradycardia can be very detrimental, and you might need to have, pharmacology drug therapy you need to go. For that, you need to give injection atropine 1 mg bolus, and it can be repeated in 3.5 ml. And subsequently, if not treated, you can definitely have an injection epinephrine and dopamine for that. Then coming to the first degree heart blocks. So first degree heart block, in this, there is a progressive prolongation of this PR interval. And usually they are asymptomatic and rarely progress to second degree, but it's just like a sitting on the time bomb. You should be very aware of these blocks and you should be promptly able to diagnose them on table so that you know what next you have to do. Then the second degree heart block has been divided into Wenke-Pack phenomena, and in which there is definitely progressive PR prolongation, where there is a dip of the P wave, which is not followed by the QRS command. Monitoring is very important in these cases. And then comes the type 2, in which they are like, husband and wife who are divorced now. The P doesn't follow QRS and they are doing their own sort of working. The same is with the complete heart block. In this, you can see the junctional rhythms, and it should be treated with the pacemaker. One important thing that is very important to win every fight, you should know your equipment. So one equipment, you need not to work for the cardiac specialist to come in your OT. If you see your defibrillator that has a pacing option, so before especially for the postgraduates, when they enter into the OT, they should see their defib and they should on the pacing. Most of the defibrillator have the instructions on that so that you can use them intraoperatively if required. So this is the algorithm that all the PGs and everyone has to be remembered by the heart. That is, first you have to see that the patient is hemodynamically stable or not. If the patient is hemodynamically not stable, is having hypotension, acute ontal metastasis, signs of shock, or chest discomfort, then you should always get treated with a pharmacological drug therapy, including atropine, dopamine, epinephrine, as explained in my previous slides. Sinus arrhythmia, these are very important and has been very often witnessed in children especially. They are the irregular rhythms which is followed by normal P and P waves and PR interval. It vary with the respiration and it is usually with the SNO pacemaker causing because of the high vagal tone. So usually they are physiological. There is an increased gap during expiration and that gap is decreased during inspiration. So the treatment usually is not required. In adult, if it happens, so your patient might be in a light state of anesthesia. You can deepen your drug anesthesia and see other contributing factors to it. Sinus tachy, it is regular and normal complexes, but P wave, every P wave will be proceeding with a QRS complex. Again, you have to rule out for the hypovolemia, fever, hunger, pain, discomfort, and especially the anemia. The acute blood loss can also lead to the sinus tachycardia. It is important in patient with the underlying cardiac diseases, as already told by my the previous speaker, that tachycardia will decrease the diastolic time and will increase the myocardial oxygen demand that can be detrimental for the patient, especially who are dependent on this diastolic filling. So to treatment, if you have ruled out the cause and you really need to give a pharmacological drug therapy, then you can give a esmolol 0.5 mg per kg followed by 0.05 mg to 0.3 mg per kg minute. Another alternative is metoprolol, propranolol, but obviously you need to know the causes for that. Then comes the premature atrial contraction. Coming to the atrial contraction, premature atrial contraction, the risk factors can be idiopathic, coronary artery disease, left ventricle hypertrophy, beta agonist, and antidepressant. As the words come atria, we know that it is the P wave that is going to be affected. So what we are going to see, it means that there is an origin from the site in the atria other than the SA node. So the impulse is originated somewhere else. So we have to rate is less than 100 per minute. It can be irregular. So what we have to see that the P wave is of the abnormal pathology or it comes preceding. So what we have to do is and one important thing that we need to know about the premature atrial contraction is the incomplete compensatory pause. In the coming slide, I will tell you how it is important. If you see this ECG strip, there is definitely P waves, alteration of the P wave, but there is no compensatory pause. So symptomatic patient only required the treatment. Beta blockers and antiarrhythmic drugs of 1A, 1C, and 3 can be think of, and other if the patient is really very detrimental, you can cause the cardiac experts and can think for the atrial pacing or ablation. Then comes the premature ventricle contraction. So usually they are less than 100 per minute. Rhythm is irregular. P wave is absent and QRS is wide and bizarre. And the T wave is opposite to the QRS. And there is a complementary pause that is present. Do we need to treat all the PVCs? The answer is no. When they are symptomatic, then the frequency is more than 6 beats per minute. They are multifocal. ROMT phenomena is there because they are the precursor which can go to VFib. So first line we can use beta blocker, calcium channel blocker. Lignocaine is the drug of choice. You can use 1 to 2 mg per kg followed by 1 to 4 mg per minute. So they are also seen most commonly in the PACU and the anesthetized patient with the pre-existing cardiac diseases and advanced ages, male gender, hypertension, ischemic heart disease, and electrolyte abnormalities should also be considered in the patient perioperatively if you are suddenly thinking that your patient is having the PVCs. So why it is important, I was asking that you may confuse our premature atrial contraction with the PVC. So you need to understand that the atrial contraction is from the foci in the atria. So obviously there is a presence of early and abnormal shape P wave and premature whereas in PVCs there is no preceding P wave. in QRS morphology is normal in atrial contractions, and whereas it is not wide in premature ventricular contraction. And definitely the most important thing, it is not followed by a compensatory pause, but definitely there is a compensatory pause, because in the atrial contraction, although the impulse generator is not SA node, but definitely from the AV nodes to the bundle of His and Purkinje fibers, the impulse is going. So there is obviously abnormality only on the this P wave. Then comes the flutter and the fibrillation. That is very important. If you see that there is a sawtooth appearance in the flutter and the fibrillation there, it means that the word literally means that the atria is fibrillating. It is not contributing much of the cardiac output. And in the cardiac patient, especially in the old, they can be very detrimental. So rate can be more than 150 to 250. Rhythm can be irregularly irregular. P wave may be absent, and QRS complex can be narrow and irregularly placed. So it comes, if the patient is hemodynamically stable, then you can go for a pharmacological drug. But any patient having any tachyarrhythmias, if you're not able to, able to distinguish between, just see it is a narrow or it is a wide. If it is a narrow and it is an unstable, tachyarrhythmias, you can directly go to the cardioversion, synchronized cardioversion you can go. So chronic AF is also very important while you're taking your patient to the intraoperatively, because this patient might require anticoagulant or to prevent any thrombus intraoperatively. So there are various guidelines, and there are various scoring system has been done to know that whether to start anticoagulant or not. And one of the most common thing, CHAT scoring, has been done, where there is a congestive heart failure, there is a hypertension, age more than 75, diabetes, or there is any type of stroke is there, then you can definitely, if the point is more than 2, then your patient is in a very high risk of intraoperative or perioperative thrombus. So flutter, we have already talked about this. Then come your rhythms. So VTAC and ventricle fibrillation. So as we already know that any pulseless VT or VF are the shockable rhythm. So you need to understand this rhythm. So the first ECG strip that is showing is the narrow sinus rhythm. The second one is the ventricular tachycardia, and the third one is the fibrillation. So you need to know whether there is any sort of drug therapy you have to do. Any unstable VTAC, you need to do the cardioversion, and the drugs you can start with the lignocaine, amiodarone, and procainamide, and anti-arrhythmic drugs you can start for that. So coming to the anti-tachycardia arrhythmias, in the perioperative period, if you have any type of tachyarrhythmia, just see your hemodynamically instability. If it is yes, you go for a synchronized cardioversion. In narrow complexes, just go for start from 50 and go to the maximum. In wide regular one, give from the 100 joule. In unsynchronized, otherwise irregular, you can go. Adenosine is the drug of choice. You can give 6 mg, and the second dose can be increased to 12 mg. While giving adenosine, you have to attach a 3-way, and you have to, sometimes pull your arm up, especially when the circulation is not there, because its half-life is very less, and you need to be very pushing the normal saline simultaneously. Procainamide, you can give 20 to 50 mg per kg. Amiodarone and sotalol are the other thing. If you have a wide complex and is not there, then you can go for a vagal maneuver and adenosine and beta blocker, and definitely I ask for an expert opinion. So my key home message is therapeutic decision in cardiac arrhythmias may be individualized, best management on hemodynamic impact of the arrhythmias, underlying cardiac function and contributing factor, and accurate diagnosis is the key. Always integrate clinical examination and ECG in diagnosis. Misdiagnosis can be dangerous, especially with the wide QRS tachyarrhythmias, leading to ineffective or harmful treatment. Accurate diagnosis is critical. It guides safe and effective therapy. Just if I can have few more minutes, I can just want to ask the audience if they can recognize these rhythms. They can type in the chat box if they want it. So this is the first rhythm, which is sinus arrhythmias. So if you just see the strip, there is an increase during the expiration, and then there is a fast rhythm during the inspiration. So Gauri ma'am is they can type in the chat box if they want to participate. The
Yes,
second
they can. Yes, they can.
Yes. So the second one is the ventricle premature contraction. You can see that the broad QRS complex inverted T wave is there to recognize this. And again, the treatment is stability or not stable. So you can see that. The third is one is you can just type out in the chat box. Gauri ma'am can give you toffees or some prize at the end if you if you just know the right one. This is simple bradycardia. And this is sinus tachycardia. One very important to differentiate between the sinus tachycardia and SVT is very important, especially in the children, because they have already resting heart rate very high. So you will can appreciate P wave in the sinus tachycardia. But when it comes to another supraventricular tachycardias, you see that there is P wave is mostly not appreciated. This to everybody can know. This is a nightmare to I think every anesthesiologist. So we have this ventricular tachycardia, VTAC. We can see that the broad complexes monomorphic is there. This is fibrillation. You can see this is very simple. I think ventricular fibrillation is there. And last but not the least, one has to be very cautious. One need to remember that the shockable rhythm has to be remembered perioperatively. VFib and pulseless VTAC are the shockable rhythm. And you can, epinephrine is the drug of choice while treating any arrest or, sort of hemodynamically you are thinking. And second is you can give a myodron, 300 followed by 150 and lignocaine. And thank you. I rest my talk, and I hope that you people be able to recognize vital ECG changes perioperatively, and you will not lose patient, giving a prompt treatment. Thank you.
Thank you, Dr. Ridhima ma'am. It was an excellent presentation, a very exhaustive topic, very well framed in a crisp, comprehensive manner. And I'm sure it's helpful for all of us as a ready reckoner as to how to identify various common intraoperative arrhythmias and how to move about treating them. So as we come towards the end of the 3 lectures, and we had the excellent speakers who have thrown good inputs on all these important topics, I would now like to invite our chairpersons, our esteemed chairpersons, if they have to comment anything specific or enlighten us further on any of these topics that these speakers have already spoken about. Dr. Indrani, madam, you have to.
Yes. Yeah, thank you so much, Shraddha. And at the outset, I would like to thank Dr. Naveen Malhotra, Vishal, and Gauri for, having me as a chairperson for this very impactful and informative kind of a session. I just have few of what do you call? I would say a little add-on to whatever has already been told in all the 3 lectures, because I have given presentations on all the 3. So the thing is, first thing is about perioperative myocardial infarction. So very, very precisely, Shilpa gave an excellent talk, and I really loved her presentation. And one thing which I wanted to add to that is, supposing you have a patient, in which you have given a block, and you find STT changes, say, for example, on table, or if you given a spinal or an epidural, you find, supposing there is a sudden STT changes coming on the scope, the first thing one has to do is to alert the surgeon, and you have to stabilize, especially if the patient is on regional, which means, as she rightly said, you have, oxygen. You have to give oxygen. Supposing there is a shock, patient has, fall in blood pressure and all that, you might even want to, intubate and ventilate this patient. And apart from all the short-acting anticoagulants, which Shilpa had already said, what I would say is, if the blood pressure is okay, then I would also want to give NTG to this patient. And of course, beta blockers depending upon the heart rate. And aspirin, you may not want to give clopidogrel, you may not want to give heparin, but you can crush and give aspirin to this patient. Okay, so that is one thing which I wanted to say. And of course, if the patient has developed cardiogenic shock, you have no choice but to give inotropes and vasopressors in these patients. And I very vividly remember when I was working in Tata Hospital, a case came to me for brachytherapy, simple brachytherapy, and the patient had, chemotherapy, adriamycin-based chemotherapy about 3 weeks before. As such, at the time, before I could give a spinal to that patient, no, not spinal. I was what I was doing, yeah, spinal. So the heart rate was already around 106. So I was debating whether to give the case, not to give the case. Then I gave the case. But then the heart rate climbed, STT changes, the works, patient went into pulmonary edema. And then, I had to call for help. And then from the regular block to the GJ block, people came running. Then we took the patient, pulmonary edema, treated pulmonary edema. Then we did a post-op, we did an echo, and the patient had a stunned myocardium. So one thing again you have to remember is these are the patients who are post chemotherapy, which are cardiotoxic. Especially if they have received cardiotoxic chemotherapy, then you have to keep this presence of stunned myocardium also in mind. So that was one thing which I wanted to say. And another thing was about the high blood pressure. And I think we have Dr. Prajakta and Geeta and other people who have worked with me in symbiosis just about 2 weeks ago. We had a patient, they called me for a patient, patient was about the surgery was over. Post-operative, the blood pressure was 250 by 120. I mean, by the time I could come, they had already given sedation, they had given everything for pain control, everything. The BP was simply not coming down. Then, metoprolol was given. We gave one hell of a lot of metoprolol, and in spite of it, the BP just wouldn't come down. It was all the time 205, 205 by 120, just BP wouldn't come down. Then we had no choice but to, start on NTG. When with NTG, with so much of resistance came down, finally, we took a central line and we started the NTG. And then, then we shifted the patient. The patient and post-operative patient did have some amount of pulmonary edema in this patient, following this. Patient went into heart failure. So there was, all this can be seen with refractory hypertension. They can go into pulmonary edema and they can have refractory heart failure. So this is again a problem with, with the uncontrolled blood pressure. And another thing which I wanted to share about arrhythmias. Again, what about VPCs? Yes, you're right. You don't have to treat all your VPCs, but there are few VPCs you have to treat. What are they? Those VPCs which are multifocal, especially if they are very frequent, in a patient having a underlying heart disease with a risk of sudden cardiac death. So these are the patients in whom VPCs cannot be taken lightly. We have to treat their VPCs. Second thing, what about patients with, say, heart blocks? In case a patient has, say, RBBB with an incomplete LBBB, we have had these things in our mind. Can we give regional to this patient? A patient comes with RBBB with an incomplete LBBB, and you can do away this patient with a spinal. Can we give that spinal? That question, what do you do? The answer to that is, in all probability, you ask for symptoms. If the patient says, I feel very exhausted, I feel dizzy, I feel like fainting, I feel very faint, or I get breathless very fast, or I get chest pain. If any of these are there, then it means you cannot give. you have to consider this patient as a patient who may go into complete heart block anytime, and consider this patient as a complete heart block. So that is another thing which I wanted to say. And another important thing under anesthesia, the arrhythmia which we get, which I have seen, is pulseless electrical activity, especially those patients who have bled a lot. We haven't assessed the amount of bleeding. Generally it is the 5 H's and 5 T's. If you treat the 5 H's and 5 T's, of course you are back to normal. I mean, we have to give adrenaline to these patients, and then we have to revive these patients based on what is the reason for pulseless electrical activity. And in all probability, those patients under anesthesia, some of the very common arrhythmia which we see is pulseless electrical activity because of, acidosis, or it could be because of, as I said, hypovolemia, which is the most common cause, hypoxia and things like that. So this is my 2 cents about whatever, about the topic for today, which is intraoperative, perioperative cardiac events. Thank you so much.
Thank you, ma'am. Learning from experiences like this only improves us better and prepares us better for any such catastrophes, God forbid, if they happen in our OTs. So now, Dr. Anjali Pure, madam, if you have to comment anything.
Thank you so much, Shraddha.
Sure.
Shilpa, I must congratulate you. You always come up with good case presentation, and the interpretation is made so easy to understand that things become very interesting, as is the case today with your case of MI.
Thank you so much, madam.
Okay. And one thing I just thought of the preoperative, the intraoperative, and the postoperative. So when you consider these particular phases in a patient, I think the postoperative period is more commoner for these kinds of MIs. And but the pre-op evaluation becomes very, very important. And especially for the postgraduates, we need to know them that what are the risk factors, what are the various risk indices which we can consider while examination. The DASI can be used. The latest guidelines of 2024 can be made to understand that postgraduates, that examination and history is going to tell you most of the things, how the patient is going to present here. So that is one important thing, and your presentation was excellent, very easy to understand. And regarding arrhythmias, Indrani madam, today we also had one case a long back, 21-year-old patient coming for mastoid exploration, and the patient was taken induced, absolutely no problem. There was a junior surgeon, ENT surgeon, who instilled adrenaline around the operative site, and suddenly the patient arrested. And we didn't know because the patient was ASA grade 1. And then later on, when the patient was revived, rest of the things were done, we realized that the surgeon had put 2 ampules of adrenaline. बहुत अच्छा effect आना चाहिए. So, we missed that finding of a junior instilling that and the concentration which he used. So I think that was a lesson for us. So since then, everybody watches what the surgeon, what is a mixture, what is a proportion of adrenaline is being used. Ball में और ज़्यादा डालो और अच्छा effect आएगा. So I expected this.
What I wanted to tell you was, whenever the surgeon is infiltrating, whether they like it or not, I always say, please aspirate.
Yeah, that I do. Even I do that. But it was when she told ना कि उन्होंने ampule डाला, तो we did. He said that कि मैंने 2 डाला ताकि effect अच्छा है. So, and 21, and all the medical legalities came, we kept thinking, what do we go and tell outside? 21-year-old patient coming for mastoid, arrested and later revived, that was okay. So that is one more thing we need to really see. Today there was a patient of lobectomy, 2 years old, and suddenly the patient was absolutely fine. Suddenly there came bradycardia on the screen, And by the time we started treating bradycardia, there was ventricular fibrillation. We again started treating ventricular fibrillation. We came till amiodarone. Suddenly the patient went into SVT and then, going to polymorphic. We just didn't know what sort of megacode is going on here. And of course, by God's grace, the patient got revived. But as you said, sometimes your day, you see so many arrhythmias coming up, and we almost gave everything to the patient, and we realized, Bapre, sab kuch de diya, including myself. And fortunately, the patient came out today. So when, Indrani Madam, I still remember you had given this presentation in Nagpur, so about the arrhythmias. And so today I realized that, oh, this mega code, what just now Ridhima told, all these things came into play. So we need to know, and the postgraduates also need to understand that even a normal patient, sometimes unanticipated, we can land up in trouble. And then medico-legally, it will be very difficult for us to prove ourselves. Thank you so much.
I think one thing I realized that I want to highlight that talking with the surgeon is also very important, and knowing the steps, especially for the PGs. You should not sit back and giving your anesthesia and then rely. So that is thing. And I think nowadays PGs are very lucky that they are having a simulation. Initially, we used to wait for arrhythmia. So the consultant used to say, you learn and I suffer. So but now simulation has made it possible and to learn all these rhythms on this mannequins, and so that your response is better when you actually face the patient. So that is what is required. The simulation drills are very important, because even if you are experienced, definitely we all freeze at one point when we just see the life-threatening arrhythmias, especially as ma'am said in ASA 1 and 2 patients.
Yes, absolutely. So this itself shows, the discussion itself shows how important this very topic was that we are discussing today, from in a broader spectrum. Dr. Geeta ma'am, if you have to enlighten us with something.
Good evening, everyone. Thank you very much. I thank the organizers, Naveen sir, Vishal, and the Nagpur team, so for giving me this opportunity. Everything has been covered very beautifully by all the speakers and added by Indrani ma'am and Anjali ma'am. I just would like to just stress upon the fact that these topics are actually important, as they have been beautifully summarized and emphasized. But this is the place to the PGs and others. I would like to say these are the place where the role of the anesthesiologist makes hell of a lot of difference. So they are of importance. If not attended, it can end up into a mess. And if well attended, it can really, like Madam has given so many instances, that patients are saved by our interventions. So right from the pre-op, we have to concentrate on the fact that if you find, while history taking, if you find some symptom which is doubtful, something going other than the routine PSC, I would request all the PGs to have that element of doubt. Anybody in the pre-op, if you have that doubt, investigate further. Usually we are doing a routine PSC, but wherever you have a doubt, as Madam stressed upon this, go and investigate further to know the reserves of your patient. How good, go for an echo, go for a PFT, whatever, assess the reserves, so that even if there's a stress, will that patient be able to take, even though his investigations may appear normal, the surgeon would say, no, it is like the investigative profile is good. But then also assess for the reserves. I want to stress upon that. Second is prepare well, as of course we do it as a routine practice, but wherever you have a little doubt, keep the cardiologist or a cardiac anesthetist team in the standby. But they would only be helpful if you have prepared your drugs well. As Ridhima said, have a defib with a pacing. You should have facility for pacing also. You can keep a temporary pacemaker. And if you're in the vicinity of a cardiac thing, and an IBP can be life-saving. So, of course, that the cardiologist would bring in, but still you should prepare, you should make it available. Okay, and then of course, the other thing is that, as Madam stressed, that post-op care of these patients is extremely important. And the role of anticoagulants as well as antiarrhythmics in the post-op should be stressed. And all these things that we've discussed can be important when they're well monitored. So the moment you have some crisis, if you have not taken a CVP line, if you've not taken an invasive arterial line, go for it so that we can monitor fast. And stop the surgeon, add oxygen and atropine at a very early doubt. Just start oxygen so that whatever is ongoing can be prevented. And in all the atropine, role of atropine, whenever the bradycardia, especially when you're dealing with regional, have that element to have that urge to start it at a very early stage so that the further progress of the disease is prevented. Plus, we should train our PGs to clinically see. The monitor follows, but clinical picture worsens before. So we should also stress upon the fact that they should, as madam said, they should not be sitting behind. They should be there and looking at things. They should predict if there's hypertension after a spinal severe hypertension. It will follow that now bradycardia will come up. So they should have a element of doubt and be well prepared for that. And the algorithm should be well taught and of course well displayed also in a place like CICUs and in the OTs. Of course, as Ridhima said, nowadays the PGs have opportunities of simulations, but still the algorithm should be at their disposal and they should be well displayed. And in all these situations, one thing I would like to stress upon is our whole exercise is to save the brain. Whenever there's a crisis, we are dealing with it, but our aim should be to maintain the mean arterial pressure above 65 so that the brain is saved and we have a safe patient coming out of the OT and the ICU. And we should also, one thing more, RPGs, they read more and they don't think of simple things first. So please think of simple things. Suppose it's a thyroid surgery, sudden bradycardia, just ask the surgeon to release. That would be a simple vagal thing. Like hysteroscopy, this you just ask them to pull out the scope so that it will be over distension of bladder, inversion of uterus, just tell them to invert. So these are simple things which should be stressed upon. We should not think, we should know the complicated thing. We should have our, we should be preparing well, keeping our teams ready, but at the same time, we should keep simple things first also in mind. Rule out simple things, some drug reaction, something which is simpler, and then go for higher things. Thank you very much.
Shraddha ma'am, can I ask one question?
Yeah, sure, ma'am.
Yeah, Indrani ma'am and Geeta ma'am, both, what is your experience regarding low dose spinal in these patients? Low
In
dose.
what MI?
Yeah. No, not in MI.
Hmm.
In cardiac patients.
Cardiac patients specifically what?
Say, suppose if a patient is
Coronary artery disease, ischemic heart
yeah,
disease.
yeah.
Patient with ischemic heart disease.
Yeah.
So again, it's like what is more important is the functional status. You know, when do they get symptom? If the patient can't even go to the bathroom and come back, if the patient is getting breathless, having a bath. So in these patients, I will not touch any spinal.
Yeah.
But if the patient is able to, walk one flight of stairs, then I will give a low dose spinal, no problem.
Yes,
The
ma'am. I think I
functional
agree with
status is
madam.
the most important.
Yes, ma'am. And ma'am, we have to give this situation occurs for vascular patients for us because they generally have those with peripheral arterial disease, they have an element of coronary disease. And still they are so complicated with a bad chest, diabetes, and then that comes as an emergency, limb-saving emergency. So we are giving regional to these patients with a good cover of anticoagulants. And so pain relief is an important factor and that is well
If
dealt
it
with.
is limbs, you can give unilateral spinal also.
Yeah,
That is also
and
that option
in fact,
also. Yeah.
regional is an advantage.
Unilateral will
Regional
be a
is an advantage.
preferred technique.
Yeah.
Thank you so much.
Thank you, ma'am. Before we conclude, there were some questions in the chat box for the speakers, so I will read it out to them. Dr. Shilpa, ma'am, a couple of questions were for you. So there was one question which said that should we allow the surgeons to use lignoadrenaline infiltration for patients with known IHD or hypertension, even if their on-table BP is normal?
Yeah, so if the patient is known case of IHD or hypertension, we allow 2% lidocaine with ADR, that is 1 in 2 lakh of ADR. We allow, of course, if the patient is aged, And then we decrease the dose, we double dilute it, especially for neurosurgeries or vaginal hysterectomies when they're injecting. So we can allow depending upon that day's blood pressure and the age of the patient.
Okay. So the next question was essentially same, which stated how much concentration of ADR do you allow in hypertensive patients?
Yeah, same 1 in 2
You've
lakhs.
already answered.
Yeah, but if it's
But
an
one more
elderly,
thing-
1 in 1 lakh.
Yeah. One more which said, can we use tranexamic acid in CAD patients coming for TKI?
Yeah, we can use. There are many references on the net, where even I have used in a patient of coronary artery disease for neurosurgery. So we can use these patients even coming for TKR. We can use tranexamic acid.
In fact, we are using Prenexa infusion in every redo case of coronary arteries.
Okay.
Thank you,
Can
ma'am.
I add one more point which Dr. Indrani madam said? So Indrani madam, regarding the crushing of a tablet of aspirin, so they say if it is only a STEMI patient and not high risk at bleeding, then you can crush that. But otherwise, none of the guidelines said that you can crush. But most of the case reports say you can, first thing you can do is if there is a STEMI, you can put a Ryle's tube and crush the aspirin tablet and give it.
That's what. But NSTEMITO is anyhow, you can allow the the surgeon to finish the case. But here you cannot even allow the surgeon to finish the case. Getting the patient into the cath lab is prime here at this point of time. And who are the ones whom you will worry about giving even those short-term anticoagulants? Who are the ones? Those patients who are having spine surgery, those who are having TURP surgeries, those who are having retroorbital surgeries, where the close space surgeries, you cannot even give those short-acting anticoagulants also. Remember that. That's what, again, another point which I wanted to tell. Thanks for reminding me this. So these are the ones who will not even get that.
Yes,
these are the
yes.
ones who will go to the cath lab just immediately.
Yes. And
Yeah.
madam, most of the reports say balloon angioplasty has come again. So is it that they just do for life-saving initial only balloon angioplasty without stent?
See, nowadays, no. It depends upon, again, what surgery. See, if it is it's a surgery where you have a lot of fluid shifts and blood losses, maybe, as you rightly said, just a balloon angioplasty. But remember, what happens? You know it better. Your husband is a cardiologist, you know it. So the thing is, a simple balloon angioplasty, the coronaries will close, Shilpa.
Yes, it goes in
It will
spasm.
not remain open. It can remain open for that time, but it will close over a period of 2-3 days. It will close. So you have to put in a stent, but now biodegradable stents are also available. So not just a bare metallic stent or the other stent. So
With newer antiproliferative
biodegradable ones
agents.
are available, which are also, which can be used in these patients.
Madam, I think it is in the hemodynamically unstable patients that it is put as a time being, and then later on the stenting.
No. Any STEMI. You cannot take STEMI lightly. Just give me a minute. There is an emergency in my hospital. I have to go back. Thank you for the opportunity. I'm getting continuous calls. Thank you so much.
Thank you, ma'am. Thank you, ma'am. No issues.
Thank you, madam.
Thank you so much.
Ma'am, thank you for being with us.
Good night, ma'am.
Dr. Asay sir, a couple of questions for you in the chat box. There was one important question which asked, in patients who are apparently over controlled just to avoid the last moment postponement, जो last moment nephridipine लेके लाते हैं या फिर the apparently controlled ones इनको previous night कुछ खिला के लाते हैं. And then on the time of surgery, the BP shows normal, but maybe the control is not so good. But the question was when to say no in such cases. If abhi ka BP is good, but you know that they have overcorrected or something, when to say no.
Yes, ma'am. Even we encountered the same thing that in the morning the surgeon takes it around. They see the BP is like around 160/90. They will give them amlodipine or some nifedipine and all. They will bring the patient. So by the time the patient is on the table, the BP will be controlled. Now here, what the questions the Rajesh sir has asked is actually right. On table, if the patient present with a raised BP, what we should do? And many a time it is controlled within midazolam. But if you see in my slide, I have already given that there are two factors that might be responsible for this hypertension. So patient factor anxiety is a very important thing that we have to address. If on table, if it is controlled by midazolam, then the patient might be anxious. The BP has been controlled, you can take the patient. On the other hand, preoperatively, the only indication of BP that should unfit the patient or defer the patient for the elective cases is only if your BP is more than 180 by 110. However, we very rarely get such patients. And even fit the patient yesterday, means 1 day prior or on the day of the surgery, is only when we consider that the BP is less. Now, whatever baseline BP we should take the patient when it is in the pre-op and not the baseline BP what we take on the table, because patient might be anxious, so that might be reason that the patient's BP might be more during that time. So that BP we don't take as a baseline. Now, when we should say no to the patient, to the surgeon, is only when his diastolic blood pressure is more than 110. This is what the literature says, and even we do practice in our institute the same thing. So unnecessarily, patient postponing only the BP is very high. Many places they don't take even if the BP is more than 140 by 90, but that is not the guidelines what is recommended.
Okay. Then there was one more question, sir, for you. Shouldn't Dexmed be the first choice in an intraoperative hypertensive crisis?
Yeah, definitely. We can use what we were talking about the perioperative hypertensive crisis, but intraoperatively, as I already shown you the table of the Miller, key depth of anesthesia is very important, and dexmedetomidine is actually a boon to our this thing. I mean, field where you can quickly control everything: the heart rate, the blood pressure, the sedation, even the pain, and also it has a very small half-life as you compared with the clonidine. So of course, dexmedetomidine intraoperatively might be the first choice also in order the patient if having the hypertensive crisis.
Okay. And there was one more query for you, sir, whether IV metoprolol can be used as a part of it.
That depends on IV metoprolol. Yes, we can use, but that depends on what thing you are using. Like if the patient is having hypertensive crisis with an ECG changes, that means the end organ, its heart is getting damaged. In order to decrease the oxygen consumption, you can definitely use IV metoprolol. The dose might be varying from 2.5 to 5 milligram IV, and then every 6 hourly you can repeat. Maximum a single dose of 15 milligram you can repeat. So already the same slide has been presented with a reference of Miller, that only if you are having tachycardia, then only metoprolol will work, not in case of hypertension. If the patient is having isolated hypertension, then you have to use vasodilator only, which might be an hydrolyzine, an NTG, an SNP, or any calcium channel blocker.
Thank you very much, sir. Lastly, for Ridhima ma'am, just a couple of questions. Is there any role of IV nicorandil in any in arrhythmias?
In nicorandil?
Is there any role of IV nicorandil in intraoperative arrhythmias? Was one of the questions.
See, the most important is you can give, but the algorithm that we say, it starts from which type of arrhythmias you are having it. If you are having a tachyarrhythmias and hemodynamically unstable, you go for a cardioversion. Otherwise, procainamide, amiodarone, sotalol, and the lignocaine are the major drugs that has been used. So, although there are researches coming on that, but they are not still now included in the guidelines.
Oh. And
I
what
think
about
sir is asking, sorry.
STEMI panel?
Yeah, nicorandil in STEMI. So what they say that intraoperatively nitroglycerin acts better than nicorandil, and all the literature, all the case reports also use nitroglycerin intraoperatively. It is more coronary vasodilator than nicorandil.
Okay. And there was one more for you, Dr. Ridhima ma'am. They had asked, there's a patient posted for TL with already fitness being done, but on table now she has alternate VPC. Should we take it up or should we postpone?
See, that is what I want to tell everyone, that although VPCs are benign, but they can progress to VTEC and cardiomyopathy and cardiac arrest. So you have to see the previous ECG. If the previous ECG is actually good. And the VPCs, as Indrani ma'am also highlighted, when you need to treat it or postpone. If it is they are bigeminy, if they are coming very frequently, and you think that is R-on-T phenomena or multifocal VPCs are coming, definitely tubal ligation is an elective case. And as Geeta ma'am also said, you can have raised a suspicion and you can ask the patient to get re-evaluate or get cardiac expert. But if it is very benign, they are coming in like, one BPCs and like that, and the patient already had in the previous pre-op ECG also there. And one more thing that Indrani ma'am highlighted is a functional capacity. If the patient is healthy, going here, very good, MET is good, and there is no symptoms, and the previous ECG and the intra-op ECG is same, then you might go ahead with the tubal ligation.
Okay, thank you very much, ma'am. So after this exhaustive discussion, we have already overshot the time as well. I guess I have taken all of the chat box questions. We have discussed in detail on at least 3 of these major intraoperative events that could possibly happen and are frequently encountered in the ORs. So it was a wonderful, elaborate and informative webinar, I must say. And to conclude this event, may I request Dr. Gauri Arora ma'am, our host for the event today, to kindly propose the vote of thanks. Gauri ma'am, please.
A very good evening to all the respected seniors, colleagues, friends, and all the attendees of today's webinar. At the outset, I would like to thank Dr. Naveen sir, President Rsacp, for giving me this wonderful opportunity to organize this webinar. I thank Dr. Vishal sir, Honorary Secretary of ISSCP, for being very supportive. It is really very heartening to see that even before the academic session started, we had a house full, that enigmatic figure of 100, and it never came down till the last moment. And I think still we have 70 plus members logged in. So I thank for this. All the credit goes to the dynamic speakers, Dr. Shilpa, Dr. Om, Dr. Ridhima, and they gave excellent deliberations, very informative talk, very lucid, and very enriching. And I thank all the chairpersons, Dr. Anjali madam, Dr. Indrani madam, she had to leave, and Dr. Geeta madam for sharing their insights. Dr. Shraddha, thank you very much. You have done a wonderful job as a moderator. And I thank all the attendees for their active participation. It has been a very interesting webinar, very enriching experience for all of us. Thank you all once again for this tremendous response. Thank you. Good night.
Thank you, Gauri madam, for the opportunity. Thank you, Naveen sir and Vishal sir.
Thank you
Dr.
very much.
Shraddha, you were superb.
And heartfelt thanks to the team Nagpur, our chairpersons, Dr. Indrani Hemant Kumar ma'am, Dr. Geeta Helawat ma'am, and Dr. Anil ma'am. Heartiest
Thank
thanks
you so much.
to our speakers, Dr. Shilpa madam, Dr. Om, and Dr. Ridhima. It was so pleasing to see houseful and houseful for the houseful time. 100 out of 100 marks, rather, I think on YouTube it was around 40. So hats off to you, Dr. Gauri ma'am. It was a wonderful presentation, and I think intraoperative cardiac events is one which attracts the most of the audiences. Thank you very much once again, and long live Research Society of Anesthesiology. Good night to you.
Thank you so much, Dr. Vishal. Thank you, Gauri ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you, everyone. Thank you.
Thank you, everyone.
ISSCP, good night.